in pregnancy. We're seeing a significantly increased risk of maternal mortality associated with sepsis. And there are a lot of reasons for that. Sepsis is not really a disease, it's more like a syndrome. And we'll kind of walk through it as we go and try to answer some questions. In the United Kingdom, back in 2014, it's more organized than our United States M&M boards that each state has. They have a national group that reviews maternal mortality. And in that 2014 report, there was 25% of maternal deaths were accounted for by sepsis in pregnancy and postpartum. That's a huge number. In 63% of those, they believed, by unbiased reviewers of charts and looking at the cases, that in 63% of those deaths, there was substandard care provided for those patients, and most of those patients were cared for on OB units. So that really says something about what we need to focus on as obstetricians and gynecologists. Risk factors really walk right down the list that we see with so many other complications that we see in pregnancy. Prima gravida, African Americans, patients with either no funding or governmental funding, patients who've had cesarean sections, assisted reproductive technology. And I think the reason that's in there is it probably outlines a group of patients that have other comorbidities and are older gravidas, frankly, putting them at risk for sepsis. Multiple gestations, and obviously other comorbidities, particularly obesity, hypertension, diabetes, lupus, all those things that increase the risk of other complications, increase the risk of sepsis. So how do we define sepsis? And sepsis, again, it's more like a syndrome rather than a specific disease. It's basically where our whole organ system responds in a dysfunctional way to infection that's going on in the body. So it's not just the infection itself, but what the infection causes within our body. Next slide. So septic shock is a subset of patients with sepsis where the circulatory system basically is beginning to collapse. They have hypotension, vasodilatation, metabolic abnormalities, and all of these things lead to a substantial increased risk of mortality. Now, sepsis with persistent hypotension, requiring vasopressors to keep their mean arterial pressure over 65, plus a lactate of over 2, really is the cornerstone of the diagnosis of sepsis or septic shock. Now, the organ systems affected by sepsis and septic shock, just go down the list, right? So the central nervous system, the altered mental status is huge. The hypotension and myocardial dysfunction because of the hypotension. You get leaky blood vessels. It leads to pulmonary edema and ARDS. They get leaky gut and get paralytic ileus. Transaminase abnormalities leads to DIC and other coagulation problems. Acute kidney injury. Thrombocytopenia is huge as a part of sepsis. And then toward the end, you get significant adrenal dysfunction, insulin resistance, and very elevated blood sugars. And it's one of those things where you can't forget that, because you've got to also control their blood. You're trying to control their electrolytes, but also to maintain those sugars in a reasonable range under 200. Next slide. So the emphasis with sepsis and management has to be on organ dysfunction, not on looking for signs of infection. And that's something that we as obstetricians aren't quite used to. Now, this is a slide from the SMFM bulletin on sepsis, and this is more from the medicine realm of management of septic patients. We don't use this a lot in obstetrics except when they're in the unit, but this is just to show you the focus on respiration, the platelets, the liver function with bilirubin, mean arterial pressure, renal function. And this, a normal score, go ahead to the next slide, in patients that don't have any problems is 0, and a score that increases by 2 is associated with a significant increase in morbidity and mortality. It's important to know that pregnancy was not in the mind of the makers of the SOFA score. Pregnancy, we know, is associated with a lower serum creatinine, much lower than 1.2, which they consider normal. And mean arterial pressure of 70 can be certainly normal in the mid-trimester. As it gets lower, but below 70, below 68, then that's more abnormal. But what I'm saying with this is that pregnancy muddies the water a little bit because our numbers are a little bit different than what our medicine colleagues are used to seeing in other adults. Next slide. So again, no baseline disease. The SOFA score is 0, increasing by 2 or more, then the prognosis worsens. Next slide. And so that tool is used as an objective measure throughout the disease process or the progression of the picture of sepsis, and it continues to get worse, and that's how you can follow the patient. So while that's a nice tool to use in the ICU and by the medicine folks, we really need a little bit easier bedside tool to use. And the quick SOFA, I think, is a good midway point for us to start focusing on that we can do bedside on labor and delivery, postpartum, wherever we are. And the 3 criteria used are systolic blood pressure less than 100, respiratory rate over 22, and altered mental status. And those are 3 big things. Now, a score of 2 or more is definitely associated with an increased risk of poor outcome. So you don't want to get to this point, but these are the basics. These are things that we all need to know. And we need to, when we start to see these things, we need to be thinking sepsis, work up for sepsis. What do we do for that? And get the proper people plugged into helping us take care of that patient if we're not certain what to do. Next slide. So important to know, you saw this, fever's not included, leukocytosis is not included. Sepsis does not equal fever, does not equal elevated white count. As a matter of fact, you can see just the opposite. You can see temperature going down and you can see white count going down. So we tend to lose focus on that and think more about these 2 things when it really is not a part of this objective measure. Next slide. So this is one that I'm not going to talk a lot about, but I like it better. It's a modified SOFA by the Australian New Zealand OB Society. And it helps you understand the systolic in pregnancy can be, 90 to 100 in some normal patients, right? We see it a lot. So it uses a little bit lower rate for the systolic blood pressure, a little bit higher rate for respiration, and they give 1 point for a creatinine that's over 1. So that takes that into account for the changes we see in OB. So I just mentioned this so that you can kind of put that in your pipe to smoke on later when you're trying to decide what am I going to use at my center to help me manage these patients that I want to work up for this. Tachycardia and leukocytosis are common in pregnancy and postpartum. And unfortunately, because they're common, we tend to just blow it off and say, oh, she's had a delivery. Oh, she's pregnant. She's in labor. She's in pain. And those things can be overlooked. Don't forget to pay attention to the obvious things and always try to figure out, why is the patient so tachycardic? Why is her white count so elevated? Is there more going on that meets the eye? And the last thing to mention, there's just no perfect scoring system for obstetrics and postpartum patients. There's just not been anything studied or tried to look at their positive and negative predictive values. So it's a work in progress. Next slide. So antepartum sepsis patients are most often non-pelvic in origin. Intrapartum and postpartum are mostly pelvic in origin, which makes sense, right? But the most important thing, I think, is that 30% of septic patients in pregnancy have no source identified. That's huge. You just wouldn't think that, but that is the case. Next slide. So you've got to focus on the system, the organ systems, and how the patient looks to you. Sources of infection and sepsis, obviously, these things everybody knows: chorioamnionitis, postpartum endometritis, and wound infections. Important to jump on those things early to prevent developing to that cascade of sepsis. The non-obstetric things that we see every day on our unit: UTIs, pneumonias. Appendicitis, GI stuff is a little bit less common, but certainly possible causes. Next slide. So the microbiology is very interesting, and it's a mixed bag. I will say that if you look at the literature, E. coli is probably leading, followed by Group A and Group B strep. Staph is right there in the middle, and then you've got the gram negatives and anaerobes. But 15 to 25% are polymicrobial. So there's just a lot of things to take into account, and really cultures are key to helping guide one's therapy in patients where you have a suspected septic patient infection. This is some data also from the UK, where they found a specific microorganism or a group of microorganisms at the base of sepsis in 64% in pregnancy. And really the clinical course was helped to identify the source of infection in 74%. So don't forget the physical exam. But again, it's important to know up to 30% of patients we won't find a source. Next slide. The management, I said culture everything: sputum, urine, wounds, uterine cultures are helpful. One thing we don't do in obstetrics very much are serum lactate levels. I want to encourage you to think about that, particularly if you've got a young woman that's otherwise healthy and she's got some derangement of organ systems, creatinine or liver or platelets, and you can't really figure it out. Think about sepsis, get that serum lactate. The key with good outcome is to start antibiotics early. The mortality rate was significantly diminished if you started antibiotics within 1 hour of the suspicion of a patient having sepsis. So starting antibiotics early, even before you have the certain diagnosis or even the specific source. Fluids you have to be careful with. That's one of the things that we've learned with sepsis over the years, particularly in obstetrics. There are fluid responders and non-fluid responders. About 50% of women will be responders, and others, the 50% won't be, and they will need the pressors. So the key is to start out gently, give 1 to maybe 2 liters. If you look at the medicine literature, they talk about giving 3 to 5 liters. That can be disastrous in these patients. They have vasodilatation, leaky vessels, and it can worsen pulmonary edema and other organ injuries. So cautious fluids, and then if they don't respond to that, it is great to use vasopressors, and we typically start out with norepinephrine as vasopressor, but whatever your intensivist lean toward is fine. Next slide. So the broad spectrum antibiotics, I'm not going to go through all this. I think, just if you look at us in obstetrics, we use a lot of AMP, Gent, and Clenda, and you look at these drug choices, bottom line is they work. And the key is to jump on these infections early in the diagnosis to prevent us from getting to that sepsis picture. Starting antibiotics early prevents disastrous outcomes. So this will be here for your reference, and you can look at the different antibiotic choices. Next slide. So just to wrap it up, I think the first case presentation we had last time, the time before our last COVID discussion, had to do with group A strep sepsis. We see it regularly. It's a killer. The old name was childbed fever, puerperal sepsis. In the pre-antibiotic era, it was a very common cause of maternal death. Not as common today because we start antibiotics more quickly, but it can easily be overlooked. Now, most of these patients have fever, but some of these patients just show up with either a low-grade temperature elevation, but almost always have tachycardia and start to have organ derangement, primarily acute kidney injury. And the key is to check for that organ injury, do a serum creatinine, do a comprehensive metabolic profile, look at the bilirubin. But group A strep sepsis is easy to treat, but you got to do it quickly because it will lead to rapid progression and cardiovascular collapse. And once you get to that point with this, most of those patients are going to not survive it. And don't forget ordering a serum lactate. If you have a degree of suspicion, do it. Then the summary of recommendations, I'll just leave with you. You can look over these at your own convenience. But the most important takeaway, strong suspicion of sepsis, treat with antibiotics quickly and do the proper labs to try to assess to see where you are in the cascade of illness. And that will absolutely save lives in these patients. We have to get out of the realm of being simple obstetricians, young, healthy moms. They always do well. Well, sometimes they don't, and they can do very poorly if we let these sepsis patients get into septic shock, and then we're chasing our tail. And we're seeing this actually with COVID as well. And, you know, we've been doing some updates on that. But just remember, consider sepsis if you've got a young, healthy mom and she's showing evidence of weird things happening. Always look for it. You won't find it if you don't look for it. Next time, we're going to talk about the sepsis bundle and toolkits. Michelle's going to present this, and I think it's absolutely crucial. That case that I presented 2 weeks or 4 weeks ago was from a labor and delivery unit, and their hospital had a sepsis bundle, but that sepsis bundle was not rolled out to the obstetrics unit because, quote unquote, we didn't think we would need it there. And when they in retrospect went out and discussed that patient, they showed very quickly if they had been adept at the bundle that was available throughout the hospital and other areas, it certainly would have had potential to make a difference in that patient. So please try to make this, and it may even be a 2-session presentation. The importance is so significant for us and our patients. So thank you very much, and I'll be glad to answer questions should you have any.
Thank you, Dr. Campbell. I'm going to go ahead and